Assalamu alaikum friends. Welcome to my channel Orthopedics Made Easy. So today I am having very interesting topic and presented in very interesting way. And second thing is it is very important in your day-to-day life and also in your final examination. It often come as a short note and in your clinical practice also. So I will start with my video. So today I have topic of pediatric fractures. So this is just cartoon for you to remember that children are not miniature adults. So if this is the giant, the smaller form of giant is miniature adult. But the children are very different and they have different physiology, different anatomy, different growth potential, and different behavior of the bone. So they should never be treated as miniature adult. So why the bones in children are different? They have high water quantity. They have more cartilage. That's the reason they are more flexible, less rigid. And they have a growing epiphysis. So this epiphysis contribute to length of the bone. Any damage to this will affect the length of the bone. And there is also an apposition growth, circumferential growth going on, which also contribute to the length. So one important structure which present in pediatric is epiphyseal plate. So if you do the biopsy of or try to see the histology of epiphyseal plate as how it is here. So starting from base, that is toward this side. Here we have resting zone or reserve zone. Here we have the cells which will multiply in future and form the new bone, then followed by proliferative zone. Then hypertrophic zone, then maturation zone. So we have four zone: resting zone or germinal layer, then proliferative zone, hypertrophic zone, and lastly maturation layer. So this is very important because any damage to resting zone, it will damage permanently and may result in sequelae. Damage result in sequelae. Then second is hypertrophic zone. Here the cells are very low. So this is the common zone where the fracture happens in the physis. Fracture happens in the physis happens. So fracture happens in hypertrophic zone. So out of this slide, you need to remember two things. There is a epiphyseal plate. In the epiphyseal plate, you have germinal zone and proliferative, hypertrophic, and maturation. So out of that, resting or germinal zone is very important because any damage to this will cause permanent sequelae. Whereas hypertrophic zone is a common site for the fracture of the physis. We'll move on to second slide. So if you see this one, this is the child sitting, Murkha baithe hua hai hai. Kuch school teacher has given the punishment to the child. So this is very important to remember. So you see what are the bones which are facing the roof or the sky. So we have proximal humerus facing the sky, distal radius and ulna facing the sky, then out of knee distal femur facing the sky and proximal tibia facing the sky. So these 1, 2, 3, 4 are the important physes which attribute almost 70% growth of that bone. So when you are squatting with keeping your fingers holding the ear, the whatever the ends of the bone which are facing towards the roof, those are actively growing physes, contributing more than 70% of growth to the bone. So here, if you see what are these, that is proximal humerus. We have here we have proximal humerus, distal radius and ulna. Here we have distal femur and proximal tibia. So these are the actively growing end of long bones. So then if you remember this figure and you can recall in your exam if they are asked anything about this topic. So to just mention here, bone ends facing towards the roof, that are the growing ends. And any permanent damage to this end, that is to germinal layer, it causes more sequelae or more deformity. And the third thing is fracture along this end. So it is close to the growing epiphysis. If the fracture happens due to the rest over or potential growth, it may remodel more. So the remodeling potential is more if the fracture happens close to the growing physis. So this is not related to today's topic, but it is just to recall your embryology. And second thing is, many time you get the questions in your PG entrance out of it. So you need to remember this phrase, to the elbow I go, from the knee I flee. This is what nutrient artery is telling to you. So elbow towards the ends of the bone, towards the elbow, nutrient artery is closure. Whereas towards the ends, towards the knee joint, nutrient artery is away from that. So nutrient phenomenon is directed away from the growing end of the bone. So as previous slide, we discussed about the growing end of the bone. The same way here, the nutrient artery is opposition with it. So in upper limb, the growing bones, as I told, it is upper end of the humerus and lower end of the radius ulna. Whereas in the lower limb, lower end of the femur and upper end of the tibia. So nutrient artery will be moving away from it. If you see, this is non-growing end. This is also non-growing end. So the nutrient artery will be towards the non-growing end. Here it will be towards the non-growing end, towards the elbow, and away from the knee. So this is what you need to remember. And why it happens is, if you see, at the time of birth, nutrient artery is there. It is in the center with equal distance from the epiphysis proximally, equal distance epiphysis medially. So, but over the period of time, what is happening is the growing end of the epiphysis is growing more. So the nutrient artery is not moving, but the epiphysis itself is moving away from this one. So hope you understand this one. So it is not the nutrient artery which is migrating, it is the epiphysis itself migrating and causing the distance from this one. So it is like here is your goal. So someone who need to runs toward the goal is moving away in this direction. So if you move away in this direction, definitely you are going to increase the distance from the goal, that is nutrient artery. We'll move on to next slide. So we have different type of fractures in children when compared to the adult counterpart. Among the diaphyses, we have 4 types. One is green stick fracture, buckling fracture, plastic deformance, and complete fracture. Complete fracture is similar to that of what we get in adult patient. But these 3 are very different, and they are particular or peculiar only in pediatric fractures, not seen in adult. Then other is facial injury. It goes by classification of Salter and Harris classification. So among this, we'll just learn little about green stick, buckling, and plastic deformation. What is green stick fracture? So you just you take a green stick and try to break it, or you take a rose plant stick, try to break it. It won't break completely. It will break on one side, other side it won't break. So because of loss of a lot of elasticity and lot of elasticity and moldability. The same way green stick fractures are. So they are incomplete fracture happens only on one side of the cortex. If you see it's fracture is happening only on one side, other side is remaining like this. Here is the X-ray picture of same one. The fracture is happening only on the one side, other side is in continuity. So it's an incomplete unicortical fracture. So what happens is due to the elasticity, the deformity recurs after the correction. Deformity recurs after the correction most of the time due to the spring action of the recalling bone. So how I explain this one is, I explain this like this. 1 second. If you see, this is one bar, this is one bar. These are 2 springs. So if there is spring, only one side spring breaks, what happens is the other side will pull it one. So it to bring it parallel, what we need to do is we need to break both the springs. So hope this is clear. So why it, if you bring it closer, again, it will go away. So this is what happens in green stick fracture. So if you feel that the reduction is not adequate, you need to complete the fracture. You need to break the opposite cortex also, then reduce it and put the cast. Because if in unacceptable condition, acceptable alignment, if you reduce it, it again displaces. So this is all about green stick fracture. The second thing is torus fracture. Torus fracture, otherwise called as buckle fracture. How torus fracture got its name? So ये कमान के नीचे you will get this pillars. No, in the pillars there is elevation here. So this is called as torus. So it resembles, the elevation resembles the same way. So that's the reason it is called as torus fracture. So most of the time it is not very dangerous and it heals by itself without any residual problem. And second thing is it doesn't need any reduction. You can just splint the patient in the same position and fracture will heal. Then we'll move on to plastic deformance. What is plastic deformance? Imagine this is the tube, plastic or some aluminum tube, and you are folding it. So before, if you give gentle folding pressure or in the either direction, it folds but not break. So the same way, if the amount of force is very less, not enough to break the bone will just change its shape without breaking. So when angulated longitudinal force is applied, the bone bends. If the force is greater than the mechanical strength of the bone undergo plastic deformation. When the force is released, bone remains in the same position and present to you as a deformed bone. So if you see here, this is not straight, it is bent here. So bending of the bone of the ulna. Ulna is bent, whereas here you have green stick fracture of the radius. So this is called as plastic deformance. Treatment is plastic deformment most of the time doesn't need treatment because of the growth potential. It will regain its shape and remodel. So splint, and if bowing is very much, then you need to go for remolding or need reduction. So when these are sometimes no patient new person who is seeing the X-ray, or most of the time they are not very obvious. So if you have any doubt like this, always take normal X-ray and measure the angles and the alignment with normal X-ray. And because the same patient normal limb will be used as a comparison or control in opposition with the affected limb. Now, the important is fascial fracture. So we already read about the layers of the fasces. From the depth to up, we have resting zone, proliferative zone, hypertrophic zone, and zone of provisional calcification. So any fracture happening through this area, it is called as fascial fracture or fascial plate injury. So it goes by name Salter's classification. Salter's and Harris classification. Salter and Harris classification. So if you are, and how will you remember it? Just remember it by mnemonic Salters. S is separation. So the fasces will plate here, the separation happens. As I told, it is happening through the zone of hypertrophy. Then A, above. So there is injury to the fasces and the fracture exit toward above the fasces. Then lower. The fracture is here and it is coming out through the lower to the fasces. It's transfascial. Transfascial. It's the fracture is there. It is going above the fasces and below the fasces. Whereas here the fasces is completely crushed. When you compare the X-ray of the normal side, you will see disappearance of the fascial space. So separation, it's moving above, it's lower direction fracture, transfascial fracture, and there is ruined epiphysis completely. This is how you just remember the Salter and Harris classification. It is very important. Sometimes it will be asked in your practical theory, and even lot of questions comes in your PG entrance examination. So always take the affected limb X-ray when you are in doubt. So the treatment is either you can go for close reduction and K-wire reduction, or open reduction when you are not getting a close reduction. So we'll do a small exercise here. This is a normal tibia. If you see, there is little separation of the tibia. So it is type 1 fascial injury. Here the fracture is there and it is coming outside the bone above the facial line. So it is type 2. Here below, type 3. Then it is transfacial, cutting the facies. And this is completely distracted. So 4 and halted and is type 5. So we'll see the X-rays of this. If you see this one, this patient has fracture of the radius. You can see the facies is separate, and in between also the small fragment of this is called a Thursland Holland fracture, Holland fragment. Okay. So this is a fracture going up. So type 2 facial injury. Okay, here if you see, this is just separation. So it is type 1 facial injury. If you see here, there is a fracture here. So it is again type 1. Only facial separation is there. This is, we have greenistic fracture of fibula. So this is how you describe this fractures. So complications of these fractures, sometimes if they are not reduced properly, they may form facial bar or facial fusion. If you see here, there is a fusion or destruction of the facies. So if there is destruction of the facies, there is no growth here, only growth on this side. So the bone will deviate this side. So if half of the facies damaged, opposite half will overgrow. So it results in angular deformity. If complete facies is damaged, then it will cause complete growth resulting in limb length discrepancy. This is all about the various pediatric bones getting fractured. I have one more important topic to you. Before this, we'll just see this one because this is most of the time asked in your exam also. What are the most common fractures? At the time of birth, clavicle is most common, second is humerus, third is femur. Whereas in children, distal radius is most common. This was asked as the PG bit. Then hand injury. आपके घर में या नहीं तो फैमिली में कोई ना कोई बच्चा दरवाजे में उंगली लाया हुआ रहता इन ड्यूरिंग द चाइल्डहुड. So this is the phalanx fracture. Hand injuries is second most common injuries in childhood. Then third is elbow. So remember, clavicle is fourth most common. It's not the most common, fourth common injury in children. Whereas among the birth, clavicle is common. Among the adult also, the most common is clavicle fracture. So just remember this because you get PG bits out of this many times. So we'll move on to one more important topic related to pediatric trauma. So here is a case of 6 months baby accompanied by a caregiver. There are no parents. The caregiver got the patient. Patient had the fracture femur. But when asking the history, the caregiver unable to give the proper history how the patient sustained fracture. Then when he examined, there are multiple bruises over the body. And just on asking the reason for the bruises, patient give history of repeated fall. Mind here, the patient is just 6 months. So there is a history of repeated fall in 6 months baby is not correlating. So if the history comes like this and the clinical presentation is not correlating with each other, then always you think of something abuse going on with the patient. घर में होमवर्क नहीं करे, शरारत करे, अब्बा मारे, अम्मी मारे, बेल्ट से, चप्पल से, हाथ से या कोई बर्तन से, तो that is not child abuse. That is the normal behavior of the parents in our families. मगर if you get this type of presentation, always think of childhood abuse. So it goes by name Caffey syndrome or battered baby syndrome, or the modern name is non-traumatic accidental injuries. So these are collection of injuries sustained by the child as a result of repeated mistreatment or beating. That is abuse. So why it is named as Caffey syndrome? Because John Caffey, he first described this multiple injuries along with subdural hematoma. So that's the reason it is named as Caffey syndrome. There was a center called as Campy Center where they used to admit this type of patient for rehabilitation. So by that name, it called as Campy syndrome. Okay. Then you need to differentiate Caffey syndrome with Caffey's disease. Caffey's disease is completely different. It is a congenital condition where there is periosteal bone reaction. So Caffey's disease is congenital periosteal bone reaction present in the babies, whereas Caffey's syndrome is non-traumatic accidental injuries or abuse injuries. So if the patient is having fracture less than 1 year of age, the most common is child abuse. So if there are what are the factors? Environmental factors, poor parents or single parents, or parents who are drug abuse, parents who are alcoholic abuse, or poor loss of job. All these are environmental factor. What are the features? Patient will be having multiple fractures. Then there are a lot of bruises, and most of the time cigarette burn marks will be there. So this, if you find these findings, then the patient is a child abuse patient. So to just tell here, one is shaken baby syndrome. What is shaken baby syndrome? This is a combination of brain edema, subdural edema, and retinal hemorrhages happening if you shake the baby abruptly. So what are the findings or X-ray finding? If you see here, they are multiple fractures or active lesions on the bone. So they have corners of the ribs are fractured. So they have multiple rib fractures, and they have femur fracture. Non-walking child sustaining femur fracture, always think of child abuse. Then they have marginal fractures of the metaphysis, marginal metaphyseal fractures. So what are these? One is multiple ribs fracture you have. Then second is marginal fracture. Then you have the fracture in various stage of healing. एक फ्रैक्चर अब हुआ, एक फ्रैक्चर एक हफ्ता पहले हुआ, एक फ्रैक्चर 2 हफ्ते पहले हुआ. So they are various stages of healing. If the patient is having multiple fracture with various stages of healing, always this should give you a clue, or you should suspect this one. So what is the treatment? Most of the treatment, they are very, non-operative only, just treat the fracture by splinting, but you always need to report to the social service agency. So that's all about today's topic. So it's little lengthy, but it was very interesting. So please like, subscribe, and share my channel. Give reviews so that I can improve in next video. Thank you.